Good afternoon, good morning, and good evening. My name is Adam Mishta, and first I would like to thank the organizers for giving me an opportunity to present at the Trombin conference. And today, during my presentation, I will introduce you a new plasma generation assay that measures the thermolytic capacity of plasma and some clinical application of this assay. So hemostasis is a process of related balance between clot formation and clot lysis aimed at preventing blood loss while maintaining vascular patency. And we all know that activation of coagulation factors and platelets leads to formation of thrombin. And generated thrombin cleaves fibrinopeptides from fibrinogen and activates factor 13. This leads to formation of insoluble fibrin network. And formation of the fibrin is the first step of fibrinolysis, and fibrin serves as the cofactor for plasminogen activation. Plasminogen is activated on fibrin surface by either tissue plasminogen activator, or plasminogen is also activated by urokinase in the solution or on the cell surfaces. Plasminogen is activated into plasmin, and plasmin aims to cleave fibrin into fibrin degradation products such as D-dimers. Fibrinolysis is also downregulated by several inhibitors. We have direct inhibitors of plasminogen activation such as plasminogen activator inhibitor 1 and 2 that inhibits TPA and urokinase. We also have two direct inhibitors of plasmin, alpha-2M antiplasmin and alpha-2M microglobulin. Thrombin to create a complex with thrombomodulin and this complex accelerates activation of TAFI. Activated TAFI attenuates fibrinolysis by cleaving C-lysine from fibrin and fibrin degradation products. And this prevents activation of plasminogen into plasmin. Plasmin is the major fibrinolytic protease generated by converting its homogeneous plasminogen by fibrinolytic activators in the presence or absence of fibrin. And plasminogen is synthesized in the liver. It is a single chain glycoprotein consisting of an terminal activation peptide, 5 Kringle domains, and a serine protease domain containing a catalytic triad. Previous studies localized a set of specific plasminogen binding sites on fibrin where plasminogen is converted into plasmin. Low affinity binding sites are located in DDE domain region on fibrin, and high affinity binding sites located in alpha C domain on fibrin. And all these sites are cryptic in fibrinogen and become exposed only during fibrin polymerization. When comparing plasmin and thrombin, two major enzymes of coagulation and fibrinolysis, we could observe some major similarities but also some differences. For example, both enzymes are inhibited by alpha-2 microglobulin. Plasmin is activated by TPA, streptokinase, urokinase on fibrin surface or in the solution or on the cell surfaces. Thrombin is activated by tissue factor, phospholipid, and calcium, but is also activated by contact activation. We observe 2 times more plasminogen than prothrombin in plasma. When we look for inhibitors, on the other hand, we observe 2 times more antithrombin compared to antiplasmin. Other inhibitors of plasmin are C1 esterase inhibitor or alpha-1 antitrypsin. And as I mentioned before, plasmin activation is also regulated by PI1 and activated TAFI. So far, coagulation assays dominate clinical laboratories. And although these assays such as thrombin generation, APTT or PT have demonstrated ability to reveal clinically relevant information, there are still many patients with bleeding or thrombotic complications that these assays cannot detect. That's why we think we should look at the fibrinolysis. However, currently, most of the fibrinolytic assays present on the market measure either the concentration of circulating fibrinolytic or antifibrinolytic proteins such as TPA, plasminogen, antiplasmin, PI1, or TAFI, or they measure final product of fibrinolysis such as plasmin-antiplasmin complexes or D-dimers. There are also assays they focus on viscoelastic properties of the fibrin, such as RODEM, TEG, turbidity, rheometry, or RHEOX. However, these assays cannot measure the enzymatic activity profile of plasmin. That is why we speculate that measurement of plasmin generation to monitor fibrinolytic function may eliminate previously unrecognized deficiency that leads to clinically relevant disorders such as bleeding or thrombotic. Several groups so far have developed assays to determine a plasmin capacity in plasma by initiating coagulation and fibrinolysis with tissue factor, TPA, phospholipids, and calcium. And these assays such as NHA, non-hemostasis assay, STA, simultaneous thrombin and plasmin generation assay, or SDPGA, simultaneously thrombin and plasmin generation assay, had revealed very interesting clinical relevant information. They also have some potential limitations. First, plasmin substrate used in these assays are dissolved in DMSO. As you can see on the right slides, as we know, DMSO might influence fibrin formation and also fibrinolysis. There is no correction for substrate consumption in these assays. There is also no correction for in-filter effect or alpha-2 microglobulin plasmin complexes. Plasmin substrate used, for example, in NHA assay is also cleaved by thrombin and factor Xa, and there is and the cleavage of the substrate by plasmin is not linear. Therefore, at Synapse, recently we developed a new plasmin generation assay to monitor plasmin formation and inhibition in plasma that is based on well-known established approach employed by calibrated automated thrombography. And in this assay, we use tissue factor, phospholipids, and recombinant TPA to trigger the reaction. We can also perform experiments in the presence of thrombomodulin to study the effect of TAFI. The results are calibrated with alpha-2 microglobulin plasmin complexes that allow us to correct for substrate consumption and in-filter effect, and eliminates inhibition of plasmin by plasmin inhibitors. This assay can be also performed in both human and mouse plasma. To start reaction, we add calcium in the presence of fluorogenic substrate. Curves are obtained with this method, provides the quantitative information on the kinetics of plasmin formation and inhibition during fibrinolysis, and are expressed in molar concentration. Multiple parameters can be obtained from the plasmin generation curve, such as lag time. This is the time when plasmin is formed. Time to peak, which refers to time when time to maximum concentration of plasmin formed during fibrinolysis. Velocity, that is rate of plasmin formation. Peak, maximum concentration of plasmin formed during fibrinolysis, and endogenous plasmin potential that describe total amount of plasmin formed during fibrinolysis. And these parameters are similar to well-known thrombin generation assay. Major improvements of these assays are plasmid substrate is dissolved in milky water, not in DMSO. We can use 3 times lower plasma volume compared to other plasmid generation assays previously developed. Results are corrected for substrate consumption, in a filter effect, and alpha-2 plasmin complexes, and our our substrate is unspecific to plasmin. Previously, we showed that this assay is sensitive to plasminogen, tissue plasminogen activator, and antiplasmin. And we also observed that it's strongly dependent on fibrin polymerization, but not fibrin cross-linking. To date, not many studies have investigated plasmid generation in diseases that are associated with abnormal fibrinolysis that leads to either bleeding or thrombotic events. One of the applications of plasmid generation assay can be applied to monitor treatment with antithrombolytic agents such as tranexamic acid. Last year we published some paper in JTH where we investigated the pharmacodynamics effects of tranexamic acid in women undergoing cesarean delivery. And in the next slides, I will tell you a little bit about this story. As you know, bleeding is bad. Hemorrhage associated with trauma, surgical complication, or obstetrical events can be life-threatening. In US, in trauma, about 40% of deaths are due to bleeding. 3 to 5% of all obstetrical patients experience postpartum hemorrhage, and this postpartum hemorrhage leads to about 100,000 deaths every year. To reduce bleeding complication, tranexamic acid is widely accepted as the prevention. And addition of tranexamic acid reduced deaths due to bleeding in women with postpartum hemorrhage, as it was demonstrated in women trial. Also, tranexamic acid decreased postpartum blood loss after vaginal delivery and cesarean section. Another big study, CRASH-2 study, showed that in trauma patients, all-cause mortality and the risk of bleeding were significantly reduced after administration of tranexamic acid. However, the effect of tranexamic acid to inhibit fibrinolysis depends on the time of drug administration. But what is tranexamic acid, or TXA? This is a small molecule that competes with C-lysine on fibrin. This is lysine analog that was discovered to inhibit binding of both plasminogen and plasmin to fibrin. And since the fibrin is the cofactor for plasmin generation, tranexamic acid reduced both plasmin generation and plasmin activity. However, a major gap is inability to measure pharmacodynamics of tranexamic acid at low concentrations. And this is because of the lack of the assay that can measure directly plasmin activity. So we had 2 major objectives in the study. The first one, to develop and characterize an assay to monitor tranexamic acid that provides quantitative information on plasmin generation kinetics. And second one, to determine the pharmacodynamic effect of tranexamic acid on plasmin generation and compare with fibrinolysis measured by another assay, ROTEM. In the first set of the experiments, we wanted to know whether we are sensitive to tranexamic acid in plasmin generation or not. So we first took normal pool plasma and spike plasma with known concentration of tranexamic acid. When we did that, we observed that addition of tranexamic acid had no effect on plasmin generation lag time, but it significantly delayed plasmin generation time to peak and reduced plasmin generation velocity, peak, and EPP, meaning that indicating that we are sensitive to to detect tranexamic acid concentration ranging between 1.5 to 50 micrograms per ml. And since we know that tranexamic acid inhibits plasmin generation, in collaboration with Homa Amhazia from George Washington University, we applied this assay to study women scheduled for cesarean section who were administered with tranexamic acid. And this study, in this project, we collected blood at 7 different time points and prepared plasma from 30 women scheduled for cesarean section who were administered intravenously with 3 doses of tranexamic acid, 5, 10, or 15 milligrams per kilogram after umbilical cord clamp. And first collection of blood was performed before tranexamic acid was applied before delivery of the baby. And then we, after the baby was delivered, then we applied tranexamic acid. And then we collected the blood at certain time points, 10 minutes, 30 to 60 minutes, 1.5 hour to 3 hours, 4 to 6 hours, 7 to 8 hours, and 24 hours post-injection. When we analyzed plasmin generation in plasmas from women receiving intravenously tranexamic acid, we observed that no change in plasmin generation lag time at 3 different doses of tranexamic acid. However, we observed significant delay in plasmin generation time to peak in all 3 doses of tranexamic acids, meaning that already 5 milligrams per kilogram of tranexamic acid was sufficient to prolong plasmin formation up to even 3 hours post-injection. Also, when we looked on other parameters of plasmin generation, such as velocity and peak, we also observed significantly reduced plasmin generation parameters after injection of tranexamic acid. We observed that already 5 milligrams per kilogram of tranexamic acid was sufficient to reduce rate of plasmin generation velocity up to 24 hours post-injection of tranexamic acid. We also analyzed plasmin generation EPP, however, we did not observe some significant differences. Very interestingly, when we analyzed and compared plasmin generation parameter velocity with Rotem parameters maximum lysis, ML, we observed that although maximum lysis detect the effect of tranexamic acid only up to 6 hours post-infusion, plasmin activation was still reduced up to 24 hours post-infusion. Finally, we also studied the correlation between plasmin generation and Rotem parameters and tranexamic acid concentrations present in plasma. And in this part of the project, we first measured tranexamic acid concentrations in plasma using mass spectrometry and detected a concentration of tranexamic acid. We correlated with all parameters of plasmin generation and Rotem parameters Li30 and maximum lysis. The result shows that plasmin generation assay has better sensitivity to detect lower below 10 micrograms per ml tranexamic acid concentration compared to Rotem. We also observed that plasmin generation parameters has better correlation with tranexamic acid, and less variability compared to ROTEM parameters. So in conclusion, based on the results that we obtained from this project, we conclude the following. We developed the assay that is sensitive to TPA, fibrin formation, antiplasmin, and tranexamic acid in vivo. We also observed that assaying plasmid generation in plasma detects clinically relevant tranexamic acid levels in vitro and ex vivo. We also observed that velocity, rate of plasmid generation, measures reduced plasmin up to 24 hours post-infusion. Parameters of plasmid generation, such as time to peak, velocity, and peak, correlated significantly with tranexamic acid concentration and showed less variability than the ROTEM Li30 or maximum lysis parameters. And we also observed that 3 to 16 micrograms per ml of tranexamic acid half maximally inhibit plasmid generation in plasma from women undergoing cesarean delivery. And we think, as the implication of plasmid generation from this project, is that plasmid generation assay is an effective method that can be applied in clinics to measure low concentration of tranexamic acid in vivo. We also know that impaired fibrinolysis can lead to venous arterial thrombosis. And the first study that investigated plasmid generation in thrombotic settings in human plasma was done by a group of Robert Campbell in collaboration with Alisa Wahlberg. And in this study, they applied plasmid generation to investigate patients with coronavirus disease 2019 and sepsis. And they found that plasmid generation assay revealed enhanced plasmid generation in patients with COVID-19 and delayed plasmid generation in plasma from a patient with sepsis. Another paper that where plasmid generation was applied in prothrombotic settings was published in Blood, and the results from this paper will be presented by Alisa Wahlberg in the next presentation. I'm really looking forward to see this presentation, since Alisa is a very good scientist, mentor, but also a very good presenter. So I'm really looking forward to see her presentation. So in conclusion, my final conclusion of my presentations are: ex vivo measurement of plasmid generation assay aims to evaluate the endogenous capacity of fibrinolysis to predict hemorrhagic and thrombotic risks. Plasmid generation assays have promising clinical and research potential in monitoring antifibrinolytic medications, screening for genetic or acquired fibrinolytic disorders, or evaluating changes in fibrinolytic system due to abnormalities in the level of fibrinolytic factors, both in human and mouse plasma. Measurement of plasmid generation may better reflect the hemostatic phenotype compared to routine tests such as D-dimer, PI1, PAP complexes, and TPA or ROTEM turbidity and TEC. And finally, these slides demonstrate several diseases where plasminogen play an important role, and we think where plasmid generation can be applied in the future. Finally, I would like to acknowledge many people from Synapse and UNC from Chapel Hill who participated in the development of plasmid generation assay. I also would like to acknowledge other colleagues from Michigan and Washington who also participate in other projects where plasmid generation was applied. And finally, I would like to thank you for attention, and I'm looking forward to your questions. Thank you very much.